Good evening, everybody. We just want to wait a couple minutes for everybody to join in. Usually just takes a couple of minutes to get everybody on and situated. We're super excited. We had a pretty good sign up for a Monday night. All right. Well, let's just get started. Well, thank you all for taking the time out of your busy schedules, especially on a Monday, for our talk here. Just a few items before we get started. Is we want to put, and anytime you have any questions during this entire process, I mean, I'm sure everybody's familiar with Zoom by now, but just in case, put all the Q&A, any questions in the Q&A box at the bottom of the screen, and we'll try to get to as many questions as we possibly can. If we can't get to all the questions, somebody from the Strata team will get back to you directly. I know you can always email us to get in touch with somebody from Strata if you need be. And lastly, too, is as far as the gift card is concerned, well, you will be sent to the email that you registered with. If there's any type of change, please let us know. And you obviously have to attend the full talk. Well, we are super lucky tonight to have Dr. Brad Glick, who I'm sure most of you are familiar with, but he is the director of residency at Larkin Hospital, clinical professor of dermatology at FIU, Herbert Williams College of Medicine in Miami. He is also a member of the board of directors for the AAD, and we appreciate all that. But also, he's also on the medical board of the National Psoriasis Foundation and the principal investigator for GSI Clinical Research in Florida. So he's going to take it away, and we're going to learn all about the extract.
Well, Kimberly, thank you so much. And thank you to Derm Authority and certainly to Strata Skin Sciences for bringing together this really nice presentation. Just for complete disclosure, you're pretty used to me speaking about a biologic or some topical therapy. What's this guy Glick doing giving a talk about extract laser? And it turns out that we've been doing eczema laser, specifically extract, since day one, since the day it was approved and could be delivered to in offices. And so we have a fair amount of experience in our clinical practice. And I'm really pleased to talk to you about what I use as even monotherapy, but as adjunctively for treating our patients with psoriasis and vitiligo and atopic dermatitis. And it really isn't precision phototherapy. So I'm very pleased to share this deck with you this evening. That's me, and Kim said some very kind words. And let's jump in and talk about Excimer laser. We'll talk a little bit of science, and we'll talk a lot about dermatologic conditions that are very nice targets for treating our patients with a variety of skin conditions. And I think what we're going to learn is that even in this really wonderful deck, there are some limitations in that. There are even some indications that might even go beyond the scope of this talk. And hopefully future iterations of this presentation will include those disease states. But nevertheless, here we speak about psoriasis, vitiligo, and atopic dermatitis. When I used to think of using the extract laser, it was really specifically for psoriasis when we first got the device in our clinic. And obviously for 7.5 million adults in the United States who suffer from psoriasis. And this was really a godsend to add to some of the limited therapies that we had at that time. Now, we have a pretty full toolbox right now with biologic therapies that have close to a 60% chance of clearing your skin 100% at the end of 1 year. But what about the other 40% of individuals who have residual lesions? This is a perfect therapy for those individuals, in addition to the topicals. And sometimes we need to do combinations really of all three. And that's just one kind of simple and humble example of where we can use that. Same goes for vitiligo, where we've really had nothing until really just this past year, where we have a Janus kinase inhibitor, ruxolitinib, for managing vitiligo. But nevertheless, there's a limited response in these people. It's a remarkable therapy. It takes a long time, as we see in our patients with vitiligo in general. But what a nice opportunity to, whether we treat patients with focused, targeted 308 nanometer excimer laser therapy, or using it in combination. And I like to say really at the start here too, that we really have an opportunity here to be able to use something that we can treat patients and do it through their health insurance and their coverage. And then that's a different kind of benefit. And yet they can still have the option, the opportunity to utilize their, for instance, where vitiligo is concerned, their topical therapies. And the same goes for atopic dermatitis, where we have a large population of individuals that are suffering with atopic dermatitis. And really for vitiligo and atopic dermatitis, we've really just in the last few years starting to get some therapies in these waves that are happening of therapies that are coming to market and specific for atopic dermatitis. But yet the disease is so heterogeneous and so variable that we need other adjunctive therapies to not only quell the inflammatory presentation, but for instance, in AD, the significant pruritic load. Additionally, we know that there are guidelines that endorse the use of phototherapy. We've known this for years. We have updated guidelines from the American Academy of Dermatology, and I would put a dash next to that and say AAD, NPF psoriasis guidelines, approved, and studied and evaluated and first published in 2019. And there's been several iterations for topical therapies, systemic therapies, and inclusive of phototherapy, where phototherapy is considered really first-line therapy. In the European guidelines for vitiligo, they date back quite some time, but nevertheless, we know for quite some time that narrowband UVB and inclusive of excimer laser can be used for individuals with active vitiligo. And really in the original guidelines for atopic dermatitis, you see the right here published in the JAD, just that they are published in the JAD for the guidelines for psoriasis. We have new guidelines that are actually happening. Just this past year, we had our comorbidities guidelines. We just got our topical guidelines in January of 23, and we will get new guidelines for phototherapy. But I think that there's reasonable update even going back to 24-14, where we know that you can use phototherapy as adjunctive therapy for both acute, subacute, and chronic atopic dermatitis. And so we know that phototherapy, and specifically as we'll talk about this evening when we discuss excimer laser and extract laser, that there is a key role for the use of this a wonderful therapy, adjunctive therapy, and for many of our patients, really monotherapy, for those patients with psoriasis that don't want to go on biologic therapies. They've not had successful responses to topical therapies, and phototherapy is not new. It's been used since the dawn of day, and going back to the ancient Egyptians, where amnimagus was a plant extract that was utilized. And the Egyptians were geniuses. They used this plant extract. It was somewhat of a slight irritant in combination with just natural sun exposure, and they got responses, to inflammatory conditions that seemingly were likely psoriasis or very much likely eczema, not necessarily so sure about vitiligo. Nobel Prizes have been won for the use of phototherapy in medicine in general, and specifically in dermatology. We know that Geckerman therapy, while old and archaic and not used as much anymore, did involve and engage phototherapy. And at the time, in the 20s and 30s, was a remarkable therapy. It revolutionized the management of psoriasis, for which there were really nothing until topical corticosteroids came along. Narrowband UVB came later. Just before that, in the 40s, we had broadband UVB therapies for treating psoriasis. Sorelids in 1947, kind of a derivative of the original plants that the Egyptian utilized and we developed this topical versions and oral versions to be able to develop a photosensitizer that could be used in conjunction with a light source. And then moving forward, I mentioned narrowband UVB came into the 80s and really was very revolutionary. And then in 1997, we really got our first introduction to the 308 nanometer focused excimer laser, which has been very revolutionary, particularly in psoriasis, now in vitiligo and atopic dermatitis, as a targeted, a precision therapy, either as monotherapy or as adjunctive therapy for treating these auto-inflammatory conditions. And of course, the 2000s have really led to a better understanding of photobiology. Why 3008 nanometers? We know that narrowband UVB works quite well for many dermatologic conditions, whether it's atopic dermatitis. This is usually in a larger box or a more focused type of setting, hand and foot devices and what have you. But that range is broad. It's not specifically narrow. This is a single nanometer focused phototherapy option for our patients with these inflammatory conditions. If we go to lower wavelengths, we have to drive greater amounts of energy with potential undesirable burning effects. And then really at higher wavelengths, we're really out of that narrow spectrum that we now know from our understanding of photobiology and immunology. For instance, in psoriasis, where there's an impact that is immunosuppressive that results in the downregulation of key cytokines. So in psoriasis, that's going to be the Th1 and Th17 cytokines. And for instance, at the other spectrum, downregulation of Th2 cytokines. For vitiligo, it's downregulation of interferons and various cytokines, for instance, like interleukin 15. Here are the devices, and these are all used in our practices. Many of you may do phototherapy. We have primarily focused on the last 20 years by using targeted phototherapy. Now, for our patients with more widespread disease, not in my specific clinic, but I'm part of a large single specialty group dermatology practice. And we have light box therapy, and we have hand and foot PUVA and other modalities to be able to treat our patients with other conditions. But I have found in my couple of clinics within our group that the Excimer laser, the extract laser, has been highly successful, particularly for those individuals with smaller body surfaces, usually in that 10% or less. And I love it because it's been great, again, for the individual who really was more about doing one particular procedure and not getting stuck with using a whole bunch of creams, or for that individual that didn't want to necessarily, especially over the years, have the potential risk of immunosuppressive therapies, whether they be oral therapies or even injectable therapies. Why eczema laser? I alluded to this a little bit already, but there are certain substances, if you will, targeted proteins that we know are responsible for the development of these autoinflammatory conditions. You know, we know that laser sources, light sources, can deliver targeted therapies. And the way that this works in psoriasis and vitiligo and atopic dermatitis really is through induction of cellular apoptosis. So in psoriasis, it's not only inducing apoptosis in T cells, but also in keratinocytes. So we know that there is this feedback loop driven by cytokines that engages both T cells and keratinocytes, which we know are highly immunoreactive cells. And really, that's one particular suspected mechanism by which eczema lasers work, like extract. But also, as we see in vitiligo, we know that there's stimulation of melanocytic proliferation through the induction of T cell apoptosis, very similar to what we see in psoriasis, but with a little bit of a different impact, and probably a little bit of a different impact on a variety of cytokines and interferons. And then finally, in atopic dermatitis, we also know that there is an inhibition, a downregulation of Th2-mediated cytokines, also through cellular apoptosis, with a reduction in IgE-mediated responses as well. Now, of course, especially in atopic dermatitis, this is not singular management. We clearly have to continue with barrier restoration. Uses of topical therapies are going to be important and collaborative when we're utilizing a focused phototherapy treatment like eczema laser. But nevertheless, it really speaks to the need for collaborative therapies, particularly in that condition, which is so heterogeneous. So where can we use this, and how have the responses been, and what have we seen in clinical studies? And there have been many clinical studies, somewhere in the neighborhood of 150 studies that have involved, at least the 308 nanometer Excimer laser and or the utilization of narrowband UVB. And what we know is that it is safe and effective for adults and children with psoriasis. Most patients have achieved approximately 75% or greater clearing of their psoriatic plaques in 10 or fewer treatments. And we do see this in psoriasis. I think for vitiligo, we know that it takes more therapies. We're doing extract laser in combination with other therapies that could be just local therapies, clearly for atopic dermatitis, where it is highly successful as well. And particularly after just the first few treatments, in the reduction, not only in the clinical appearance of atopic dermatitis, but also in the reduction of itch. And I think that we really see the most successful responses when we're treating those plaques that have become prurigo-like. And we also know that in improving barrier function and reducing inflammatory cytokines, we'll also get reduction of Staph aureus in the stratum corneum and in the skin, and probably because there is an abundance and an increase of antimicrobial peptides. Various combination therapies, I've kind of alluded to this already, and it makes perfect sense. We can certainly use this therapy as a monotherapy, but using the excimer laser in combinations, for instance, in our psoriasis patients with vitamin D analogs, topical calcium urine inhibitors, certainly topical corticosteroids. One could even throw in there, even though it's off-label, but using topical Janus kinase inhibitors can be used. Obviously, we're doing that for atopic dermatitis as well. Narrowband UVB with biologics, so excimer laser with biologic therapies, and many of them have actually been studied in small clinical trials, physician-initiated trials in the past, showing successful responses. And so this is really the perfect opportunity for us to be able to use excimer laser collaboratively. We see this in vitiligo, and I can share with the group that right now, our combination of choice, it used to be really use of topical calcium urate inhibitors in combination with excimer laser, usually about 20 to 30 treatments, but we're now beginning to use a lot of ruxolitinib cream in combination with excimer laser, and it is a fantastic response. I've actually got some great pictures of about 5 particular cases that we actually hope to publish. Narrowband UVB in combination with biologic therapies, dupilumab, as you see at the bottom there. It wouldn't exclude the possibility of other biologic therapies like tralokinumab. And we can be versatile here with, once again, we have a device versus utilizing and having to approve therapies that are in a setting of that, that pharmacy benefit, for instance, and take that into consideration when you're looking at options for your patients. This is a 308 nanometer monochromatic UV excimer laser. You'll see a couple of different versions of the box right there to the right. I happen to have the extract velocity, which is on the left right there. There's a newer device to the right, which my colleagues, if they wanted to jump on in the end to tell you more about. Here are the indications. We've discussed 3 of them. Leukoderma is kind of a very broad spectrum. I think that if you have someone with unexplained leukoderma, it's not specifically vitiligo. This is another indication for this device. If you've tried other particular therapies to try to regenerate pigmentation, this would be a nice option. So let's dive into the specifics of targeted disease states where we can use the extract laser. Let's go over some clinical studies, and there have been several clinical studies. The excimer laser has been cited in over 86 peer-reviewed clinical studies, and here are just 4 of them. Probably the most representative of these 4 is one that was done by Feldman, about 80 patients, about 10 treatments here. And what I wanted to highlight for you, 72% of those individuals had about 75% or greater clearing per their modified PASI scores over an average of about 6.2 treatments and 84% after about 10 or less treatments. And I can tell you just from my personal clinical experience, that's going to vary. It depends on response. Some patients may need more. Some patients may turn around very, very quickly. And so that's going to vary. And we take it week to week, if you will. This is going to be 2 treatments per week. And we're going to get into a little bit more detailed dosing and what have you in a couple of moments. What about scalp psoriasis? I mean, it's so difficult to treat. Pardon me. And regardless of the therapies that we have, and we have new ones that are here, I think we'll all agree that even our dramatically effective biologic therapies, if there's an area where there is some resistance to response, it's often in the scalp. Topical therapies are messy. To be able to have a therapy that you can use right in that specific area and utilize it over time, and yet still in combination with local therapies and with even systemic therapies, would be of significant benefit. So this is a nice study that was done by Morrison and colleagues. And they had very significant response rates where close to half of the subjects got about, 50 to 95% clear. And again, close to half of them were over 95% clear over time. And these individuals averaged in that range of about 20 treatments. Remember that the scalp is a little bit more resistant to treatment. And so again, monotherapy combination therapy, all possibilities for our patients. This is a very nice picture from Jim Spencer from St. Petersburg, Florida, and just a really nice response after 12 treatments. This is obviously someone who's got scalp involvement, pardon me again, but also some involvement onto the face, which brings up to me some of the challenges that we have when scalp psoriasis moves on beyond that hairline, or when we have it in that retroauricular region or in that preauricular region. It becomes a little difficult because then topical therapies, we don't have a lot of choices. We end up having to use things that are non-steroidal. We haven't had a lot until recently. Which, again, with the newer generation, arrow hydrocarbon receptor agonists and tapinarof, and we now have roflumilast, there are some intriguing possibilities for our patients for collaborative therapies. Here's another example: really significant palmar psoriasis, recalcitrant to treatment, recalcitrant to topical therapies, recalcitrant to systemic therapies. Here's an individual who's having 2 treatments per week. You can see what happens just after about 12 treatments. And again, thicker areas, glabrous type skin, scalps are going to be a little bit more difficult to treat. They're going to require a few more treatments. Areas across the abdomen, face, sometimes along the hairline, not specifically the scalp, more in that 8 to 10 treatment domain. Very nice responses here. And again, these are patients that are using emollients, obviously, and they're using topical corticoids. Here's just another clinical photo where you see someone who's before treatment, a typical well-circumscribed pink to salmon colored silver scaled plaque, which after 13 treatments essentially is clear or pretty darn close to clear. Maybe there's a little hint of some scaling, mostly post-inflammatory erythema, perhaps just towards the bottom third of the picture, we see a little residual plaque. And again, using this in combination with topical therapies, whether it's corticoids, TCIs, or some of the newer generation therapies that I just referenced in our arrow hydrocarbon receptor agonists, and also our phosphodiesterase 4 inhibitor in roflumilast, really nice opportunities for us to perform collaborative therapies. Let's talk about vitiligo, another disease state target for the use of extract laser. There's been over 70 peer-reviewed clinical studies specific to the use of excimer laser and or narrowband UVB. There's just a couple of them here. And if you see these studies by Shi, Esposito, Hong, and Tanaka, basically, if you look to the right, what's most interesting to me is where you get that greater repigmentation. So at 75% or greater repigmentation, if you look in this investigative blinded study, it's a small n of 14, but nevertheless, we see significant responses where over 85% of individuals achieve this significant improvement of their pigmentation and their vitiligo. And there are other studies that have been done with more modest improvements, as you see in this. They're all small studies, and I think that we need newer studies. But again, this is narrowband UVB versus extract laser. We look at the study by Hong, again, a small n, but you have 45% of the subjects achieving somewhere between 25 and 75% repigmentation versus just 4% in the narrowband UVB group. And then you see the responses in the bottom study, a slightly bigger n at 15. And I think that we just saw in the previous pictures, and you'll see here, that these are difficult to treat areas. Hands and feet, axillae, face is really where we see the greatest responses. On the tops of the hands sometimes as well too. Areas where the skin is a little bit more flushed, if you will, with blood flow, and areas that have also been to some degree previously sun exposed. We tend to see greater responses too. And again, I think the best opportunity for our patients is to use this device specifically in vitiligo, not so much as monotherapy, but in combination with topical therapies that have been effective both in the past and currently with vitiligo. And again, referencing that we have a new FDA-approved treatment topically for vitiligo. This is a very nice study done by Hattie and colleagues a number of years back, but nevertheless, it just shows the consistency of responses, mostly where we see responses in vitiligo that is localized on the face, where the results are the best, the head and the scalp. So head and neck tends to do the best. Now, a lot of our patients come in, and I have my patients I mentioned before on combinations of topical, even some on systemic JAK inhibitors. The area that I want to mention here, the genitalia, is incredibly frustrating for our patients. And, they're afraid to talk to us about it. They really don't want to bring it up. And just like our psoriasis patients, I really think we're obligated to bring this up so we don't miss these areas, so we make sure that they're treated. And that's not just inclusive of topical therapies, but also extract laser. And we see these robust responses where, we get over 50% responses on the face and the head and neck, pretty comparable data, both 50% of the improvement and also 75% improvement, as you see in those orange bars, and nice responses as we look in the trunk, less so on the extremities. It gets a little bit more difficult on the hands and feet. But I do find, at least in my clinic, depending on the severity, and of course, important the duration, the longer the vitiligo, the longer the presence of disease, the more difficult it is to treat. And what we see to the right in this study, in the N of 221, which is a nice N, that's the number of lesions in total between all these areas that were treated. And it's an N of close to 100, but we see very nice maintenance of holding of that pigment reduction and improvement of the repigmentation during a 2-year follow-up. Again, using extract laser in conjunction with topical therapies. This is a very nice study that was done, and I think the most important component of this very nice study that was done just really a few years, a few years back initially, and published just last year by Nanette Silverberg, who's a pediatric dermatologist in New York, really looking at repigmentation rates of patients with eczema laser and topical treatments. And so these individuals used a tacrolimus ointment in combination with extract laser. And you can see the most robust responses were on the face, then the body, and then the extremities, as we would expect. Here's what's most impressive. It's not just 87%, 80% body, the 62% or responses in these particular areas in terms of their initial repigmentation, but look at the consistency in terms of the retention of repigmentation, 3.4 years of follow-up. And so when I said that this study was done a while ago, it was started somewhere around 2017, 2018, and then they carried this out over time, and they got a number of individuals to stay into the trial. And we were able to see that there is an ability with combination therapy for individuals to maintain their responses over time. And from a clinical perspective, these individuals may need some touch-ups over time as well. Silverberg and colleagues also were able to demonstrate a proportion of patients achieving repigmentation as we divided it up by location in terms of who got complete repigmentation, who got subtotal repigmentation. So subtotal would be between 80 and 99% repigmentation. And that's a really high bar. I mean, even good between 70 and 80%, up to 80% and good. And that's what you're seeing on face, body, and extremities, mostly with the orange and that dark blue color that you see in face and body, and really less so on the extremities. And I think, again, talking about that blood flow, head and neck tends to do better with than the extremities. And we see this in a number of dermatologic disorders, particularly when we're talking about phototherapy and in some respects, responses to other therapies. Some clinical photos. This is an individual who was treated with extract laser for vitiligo, and you see her just after 5 treatments. Look at her baseline. She's getting repigmentation pretty early on, 15 treatments, 29 treatments, and you can see it will require a number of treatments. And we have some patients where we're doing in the neighborhood of 40 treatments, and we'll be using this in the modern day with topical Janus kinase inhibitors, but we've done this most commonly in the last 5+ years with topical calcineurin inhibitors like tacrolimus and even pimecrolimus. Just some more before and afters. This is nice pictures from Ken Beer and Joe Weibel. Very difficult to treat on that nasal dorsum. And after 20 treatments, this is going to be a very happy child. And that's the nice thing. We look at these studies. If you look at Silverberg's study, I believe her population, even though it was pretty small, about 15 people, 8 years old to 81 years old. And so the nice thing about this is we also have a versatility of the age group. And unlike prescriptions sometimes where we have cutoffs and we're not able to use certain therapies, here we really don't have those kinds of limitations. Let's talk about eczema, atopic dermatitis, hand eczema. Great opportunity for us to have therapies for our patients, which this particular condition can really fool us and be extremely difficult to treat. And while we have new therapies now, we have biologics, we have Janus kinase inhibitors, we have other therapies coming. The responses that we see in eczema and in atopic dermatitis are very limited compared to conditions like psoriatic skin disease. And so we see this very nice study done by Schroff and colleagues, published a number of years back, about 6-7 years back, an N of 30. And we're looking at pre and post-treatment physicians' global assessment scores. About 87% of the subjects in this study achieved clear or minimal disease. Over 2/3 of the subjects had a reduction in their PGAs after an average of just 13 sessions. And so that's about 6.5 weeks, statistically significant in that regard in terms of reduction. And I think if you look at it in actual numbers, getting to clear or minimal disease, most of these subjects went from 3s, moderates, down to 1 most of the time. A 2-grade improvement from baseline is a very high bar in these clinical trials. And the average duration, patients remain disease-free with no relapses after treatment with their eczema. This being, again, chronic hand and foot eczema, was about 11 months. Again, in the same study, if we kind of substratify pre and post treatment severity scores in terms of improvements of erythema, scaling, lichenification, vesiculation, localized edema, cracks and fissures, pruritus, and then the overall modified total localized skin responses, if you will, there was a 75% reduction in those modified total lesion symptom scores that these patients. And so that modified total lesion symptom score is not only a clinical response of the improvement of the appearance of these lesions, but also the simultaneous improvement of their itch and their pain. So that's impressive. Here's some other clinical photos from the same study. So you see the erythema and cracking and almost fissuring in those toes, with essentially complete resolution after treatment, just from left to right on the left side of the screen. The individuals in this particular study had an average of about 13 treatments. I think that's actually pretty good. And here's just a before and after with significant improvement on the distal hands on those digits. What about using extract laser and optimizing its use in clinical practice? Where are we going to use it? Who are the patients? Well, we've gone over this to some degree already, but localized plaque psoriasis patients, they're usually going to be in that about 10% BSA area. I mean, a lot of that's going to be up to your clinical judgment. It's going to be up to the circumstance. It's going to be up to what prior medicines that they've used previously. Often they have recalcitrant plaques, as you see here. They've not responded maybe to conventional phototherapy. They need more targeted therapy. They may not be responding to local therapies and also biologics and systemics. The same goes for vitiligo. We're wanting to really treat individuals at about that 10% body surface area or less. The head and neck is going to be your areas that are best bet, upper chest. We treat the top of the hands periodically. I mean, they're limited, and certainly the genitalia. When we ask about this, we make sure that we're treating with someone who has vitiligo on their face. We're making sure that we ask, where is it everywhere, and make sure that we're addressing that, because the device can be used in this area. Also in atopic dermatitis, moderate to severe lesional skin, those that are refractory to topical therapies, maintenance therapy, and chronic disease. And I would say that even though it is a focused, remember, it's a 4x4 centimeter squared targeted device where you're delivering it, if you will, in pulses of energy, it also has been effective in my patients in reducing their itch. You want to make sure that you use appropriate first dose values. Now, that's going to vary anywhere from, let's say 100 to 400, 300 or 400 millijoules in that first treatment. It also depends on skin type. Those fairer skinned individuals are going to have lower fluences. Those that are of the darker skin types, those individuals with thicker skin, those thicker locations, elbows, so the bony prominences, the sacrococcygeal region, you may start with a first dose that's a little higher, but that's key. The optimum dose, how is it verified? We verify it by a consistent, moderate sunburn type reaction. So a little bit beyond what we would call a minimal erythema dose, but we're looking for that, light pink erythema. There may be a little bit of tenderness, and it might last 1 to 2 days about 24 to 72 hours at max following treatment. And sometimes when someone's further along in their treatments and we're using higher fluences, we might even take a little break from therapy. A little bit of superficial blistering is not uncommon. And clinically speaking, we often like to see this because we know that we're going to get an effective response. And that's really across the board in all three of these conditions. But I say in my camp specifically for psoriasis, we increase doses as recommended in percentages. So we reach these optimal doses and we get quicker responses. And so that's going to be in the range of about 15 to 25% per treatment. At very high dose settings, some patients may notice a warm sensation, and that's not going to be in the first few treatments because this is also time-based in the energy. But when we expand that energy that we are delivering, those fluences that we're delivering over time by 10%, 15%, 25%, we may have a little bit of warmth, particularly further down the road when we get to treatments 10, 12, 15, and even 20, depending on the disease state. So here's it's just some framework in terms of initial dosing for the extract laser. Now we have the Fitzpatrick skin types to the left. I mean, I think that we are utilizing this, but I think that we have to size our patients up, very carefully based on the disease state that they have. Is it psoriasis, vitiligo, or atopic dermatitis, or localized eczema, hand and foot eczema? And then not just even the Fitzpatrick skin types, but because of the locale, let's use psoriasis as an example. Someone who has a darker shade of skin, someone who has a bony prominence that is involved, you're going to be probably driving a greater initial fluence. Here you see to the right, you determine the plaque thickness. This is using psoriasis as I'm indicating. And depending on the skin type and presentation, here you have your ranges of initial dosing based on skin types, about 1 to 3 and 4 to 6. And so we're going to start in mild cases or even moderate cases in that 3 to 5 or 600 millijoules per centimeter squared domain. Now, when we get to really thick plaques, like you see to the right, we might even start higher, but for me personally, I would say that with caution. I'd rather not get too much early blister formation. I'd rather get that nice sunburn response, and after a few treatments, maybe start to see very, very minimal amount of superficial blistering. And this is actually what we're referencing right here in subsequent dosing. Now, if someone doesn't get any effect whatsoever, no erythema, no tenderness within a day or 3 days of therapy, if they tolerated their treatment, we're going to boost that fluence by about 25%. If their treatment wasn't tolerable, then we might only increase the dose by 10 or 15%. Was the patient's treatment tolerable when they had a minimal effect, as we see to the left here? If yes, then we're going to increase by 15%. Now, if we had minimal effect, if we started to get a little bit of that erythematous hue, we see that sunburn effect, well, if their treatment was uncomfortable, then we maybe maintain the dose. And you want to use practical experience here. If I jump down to the bottom with severe response, severe effect, we might be a little bit more cautious. If they tolerated it well, we're going to go up by 15%. If not, if they had no issues with tolerability, then we might reduce their effect. We might reduce their dosing. And that's what we'll see in those severe effects at the bottom. So these are reductions. Someone who has a good effect, but they had intolerability, we might go down by 15%. If you see at the bottom here, severe effects, for instance, was it tolerable? No, it wasn't. They got a really significant sunburn effect, maybe getting some blistering. We might even go backwards a little bit and reduce the dose by 25%. I find that I don't have to do that. I graduate my therapies pretty carefully, and we don't get profound, significant deep red hues that result in discomfort with patients. But, we sometimes have to break from therapy, or we will rarely reduce dosing, as is indicated by here. And at the bottom, to finish this up, blistering, was the patient's treatment tolerable? Well, they're blistering, so it's very unlikely that they're comfortable. And here's where you might just go down a little bit by about 25%, because you really don't want to be treating on blistered areas, and you want these areas to involute to some degree. Here are just some other examples of dosing regimens by specific area. So you see, we'll go periocular, about 100 millijoules per centimeter squared. We'll go down to the elbows. Remember, I mentioned the bony prominences. We may start a little bit higher. If the disease state is a little bit more severe and that moderate to severe and there's significant hyperkeratosis, we might even start a little bit higher than 300 millijoules. And again, sometimes we do dose escalation in millijoules. So if one has no or minimal effect or slight or no erythema just within that first day or so, we might increase the dose by 50 millijoules per centimeter squared. And of course, this is in vitiligo. And there are differences here because, in vitiligo, we're not really talking about hyperkeratotic plaques. We're really talking about loss of melanocyte proliferation. And so here our doses are adjusted a little bit differently. So for instance, if we're talking about a knee, knees are very difficult to treat because the knees in and of themselves are kind of hyperkeratotic. And we'll start with kind of higher and deeper fluences. If we get a moderate or good effect, we maintain the dose over time. We take our time. And remember, much of the time we're using this with combination therapies. If someone has a severe effect, they have extreme erythema with or without blisters, we're going to possibly reduce the dose by about 50 millijoules per centimeter squared. And when there's significant blistering, we might hold therapy and then wait a few days and then treat accordingly. But overall, we might reduce the dose by as much as 100 millijoules per centimeter square. And just remember, the company Strata Skin Sciences provides an exceptional degree of, if you will, extract university here and provides you with ability to really understand what therapeutic responses actually look like over time. And a lot of that comes with experience and over time. In terms of setting patient expectations for the Excimer laser, for extract laser, scheduling appointments, we're pretty much averaging 2 treatments a week. I think for vitiligo, sometimes we will go 3 times a week, but we want about 48 hours in between those sessions, as you see above, really for all disease states. There's some variation in the numbers of treatments that you're going to need. I mean, in psoriasis, it might be as few as 6 or 8 or 10 to as much as 20 sessions to get clearance. For vitiligo, in the neighborhood of 30, and fewer for atopic dermatitis. Or if we're looking at hand and foot eczema, we can get some really nice responses in a fairly short period of time. Remissions will vary, but they can be as long as 6 months, really, for all disease states. And we even see this in vitiligo, and really even sometimes a little bit longer, and particularly when we're using combination topical therapies. And when we get those patients to a significant degree of follicular repigmentation, and then ultimately a repigmentation diffusely in their area of involvement, any other residual areas that they may have, we can either continue therapy and or support that, especially now with the use of our topical agents that we have that are FDA approved. Just a general disclaimer and comment at the bottom: moderate skin tenderness, similar to a moderate sunburn lasting about 24 to 72 hours, does indicate a nice therapeutic response. And again, just because someone has blistering, doesn't mean that there's something bad has happened. And you can see this right here. That's why we have the slide. So here's someone with pre-treated plaques with psoriasis. To the right, you see 11 treatments. We see blistering fairly early on, maybe even the first 3 to 5 treatments, sometimes a little bit later down the road. And we went over some of those basic adjustments, and there is a little bit of trial and error and feel involved here. And warn your patients about the possibility of hyperpigmentation. So here's an individual that after 13 treatments, you're starting to see some post-inflammatory erythema, some post-inflammatory hyperpigmentation, and there's essentially complete resolution, not only of the plaques, but also the post-inflammatory changes that I just referenced. In terms of pre and post treatment instructions, we want patients to come in with clean, dry skin, no lotions on the skin, discuss which effective areas are being treated, make sure we're very careful about what we're treating. We're going to have our patients wearing protective goggles. Because it is phototherapy, even though it is targeted and it's away from the patient, nevertheless, we have our patients wearing goggles. It's a must. And post-treatment, obviously schedule the next appointment. We want to make sure that those treatments are timed properly about every 48 to 72 hours, twice a week. Want to keep those areas out of the sun. And I am, a moisturizer freak. I like my patients to be moisturizing, whether they have, atopic dermatitis, hand, foot eczema, or psoriasis. Obviously less so in vitiligo, but I think patients that are getting a little bit of that slough, they may get some superficial blistering. I have them using emollients accordingly. Here are the codes for the different sizes or areas that you're treating. So up to 250 centimeters squared, code 96920, and so on between 250 and 500, 21, and over 500 centimeters squared, 22. Those are undergoing revision. Hopefully the way codes go these days, hopefully we're going to get an increase. I'll keep my fingers crossed. I know that the RUC and CPT committees are working very hard on this so that we get actually reimbursed for what we do. Here's the Extract Partnership Program. I've been working with, it's now called Strata, but I've been working with the companies for many years. And really they have been so helpful in helping us set up our practice, help us with advertising, co-op advertising. It's a very interesting business model. There's no upfront capital expense. And again, as I say, they really help you a lot with your marketing and being able to develop this program. Here's the Extract Partners Program, which basically highlights their marketing support. They have field service support. The lasers can be upgraded. I will share with you that if there's any technical issues, they are Johnny on the spot. They answer you back right away, literally within minutes, if you will. These are devices that sometimes need some change out, the gas powered. They'll have a device and or gas replacement within 24 hours into your practice. And so it is very helpful, particularly for the components of the device that are consumable. So in conclusion, the Extract laser delivers targeted therapy. Remember that 300 nanometer, that very precise narrow band that we're utilizing in treating patients with psoriasis and vitiligo and atopic dermatitis. We looked at studies where we saw improvement of these conditions, and we see this in clinical practices. Advantages include the ability to achieve extended remissions accordingly. And we can use this as monotherapy, but again, I use the word collaborative therapy. It allows us to be collaborative with many of the therapies that we're using for our patients right now. There's favorable insurance reimbursement. And with that, I'm finished. We've got some time in the neighborhood of about 10, 15 minutes to answer questions. So Kim, thanks a lot. Thanks to Strata. And I'm very happy to answer questions.
All right, so everybody, please put your questions in the Q&A box and we will get started. Is there any specific protocol when treating the ears? And should the ear canal be covered?
Yeah, we do, just because we want to keep it focused. Now, if there is involvement of that outer portion of the external auditory canal, we want some treatment, but we basically put, kind of a very, very damp gauze in that area just to protect the actual ear canal. Okay,
are there any, this might be a question more for the Strata team. Are there any additional videos available on performing the Extract laser on different areas?
I don't know if John or Brenna want to jump on. They can really answer. Kim, I see another question here too. Do you have to avoid Excimer laser in individuals of color? And the answer is no. I mean, these are our highlighted individuals who we want to treat. Yes, we can.
If you're doing it on the scalp, can they also color their hair, or do they have to stop using products in their hair?
Unless we start to see some photosensitive type reactions, I think they can. I would not want to be doing Excimer laser, let's say within 72 hours of hair coloring, because sometimes they get a little bit of irritant reaction, and so you don't want a complicating factor. But I think that people have to live their normal lives, so my answer is yes, they can. I just would time it properly so that there is no extemporaneous inflammatory burden.
Okay, great. Do you have to avoid the laser in certain skin of color patients?
Yeah, I maybe when we were kind of balancing those two questions, no, I mean, we can treat these patients. You can treat really all skin types. I would say, though, that depending on the disease state, because there's a lot of variables here. If we have a darker shade of skin, we're going to start with that optimal first dose. It's probably a little bit higher. If we're talking psoriasis and it's a bony prominence like an elbow, we're going to use a higher fluence. And as a general comment, I would say that From a company perspective, they're going to really assist you and your staff with the tools to really understand these different gradations between the different disease states and the different skin color types.
Okay, what else? After successful treatment of vitiligo, have you seen reoccurrence?
Well, I think as a disease state, we see recurrences of vitiligo. The nice thing about it is that when I have successfully treated patients, let's pick an example, and I'll use a couple of them, mostly on the face where you can see, even in the small clinical studies we showed tonight, we get these 80+% repigmentation in terms of the numbers of subjects in the trial. But when I have had patients, whether it's TCIs used in combination with extract laser, we've had patients have remissions that are permanent. We've had patients that have remissions that are 2 and 3 years or longer. And sometimes we have to jump back in and either do some focal therapy or sometimes a topical over a few months is helpful in restoring those areas where they have lost some repigmentation. We certainly don't want them to get stuck in a period that when they see some regression and they see some return of their vitiligo, we don't want them waiting months to come in. We want to see them and treat them promptly.
Okay, great. And I know you touched on this, but they had some more questions on the genital skin treatments.
Oh, on genital. Yeah. So, I mean, I think there, again, depending on the presentation and the amount, you're going to start with somewhat lower fluences because the skin is a little different. And I'm assuming they're referencing vitiligo, but it's a highly effective therapy in that area. And those are areas where we don't get the dramatic responses that we do on the face and head and neck, for instance, or where we will, let's say, on a hairline when we're treating the scalp. But we can get effective responses. And I do think this is a perfect example of collaborative therapy, whether it's TCIs or utilizing extract laser in combination with topical Janus kinase inhibitors.
Okay, does it work for nails? Wait, does it work for, I can't, it's not really clear what the question is.
No, I think that's fine. I mean, that's a fine question. I mean, you know, when we think of psoriasis, and I think that that's what the individual is asking, they're asking about maybe some nail changes that we see. People who have chronic hand eczema will get some nail changes. And my experience has been that it's slow, but it does work over time. Now, nails themselves are going to require some longer treatments because the nails grow very slowly. There's a nail plate overlying the area, their resistance, and that really is kind of off of where the studies have been to. That's just my personal experience. And we'll usually do that in combination with not only topical therapies, these patients are often on systemic therapies, and these start to become kind of last resorts additions, if you will.
Okay, anybody else? Any other questions for Dr. Glick? There will be a recording of this session available probably by the end of the week. You guys can reach out directly to Info at Dermatology Authority or anybody at Strata. We will get that to you. Is there any other clinical questions for Dr. Glick? Oh, do you taper patients off the laser treatments?
Taper off the laser therapies. And I think that question was one of the questions on nails was from Eve Lowenstein. Hey, Eve, how you doing? You know, what we'll do is as we start to see significant improvement, we might go, and I've done this in the past when people are turning around, but they have some residual effect. We might sometimes go to once a week. As they are turning around. And again, that's going to depend. Is it monotherapy? For monotherapy, I'm pretty much doing treat to complete. I'm doing 2 sessions a week, and I really don't like to deviate from that. But I have someone where I'm doing it focally, and they're really responding well, and they might be on a biologic or a topical therapy. Then we might go to once a week until there's complete resolution.
Okay. Does oil application before laser improve penetration / decrease reflection?
Can you repeat that? Because I'm hearing something about reflection with what?
It says, does oil application before laser improve penetration / decrease reflection?
Yeah, I think that this is kind of a controversial question because you might think it might create a greater window, but I think even the company kind of prefers that we don't put anything on the area prior to the application. We tend not to do that.
All right, well, I think that really sums up everything. And last chance to ask any questions. John, do you have any?
Hey, Kim, I just wanted to say, and John has really come on to camera. If you want to just answer, John, make some final comments, and I can make a couple final comments too, just about if there's access points, if there are videos, because I think that's a really nice question that the audience has asked in terms of what Strata Skin Science may have available that's accessible.
Yeah, I can answer those two questions. There's a question here, number one, about any videos available on technique of performing the extract laser on different body areas, hands, feet, etc. Yes, there are. We have a team of clinical specialists. They're able to come out to our, to all the partner practices, give trainings, refreshers. We have a video series as well. So contact your Strata sales rep and they can put you in contact with those resources. There was a second question about any guidance on steps to get insurance to cover extract for AD, atopic dermatitis. They often get denial. So we also have extract support specialists and a benefit verification team that can help you with claims and reimbursement. That's also another value-added service we offer to our extract partner practices. So you can contact them at 1-800-974-8958. There's additional resources on our website. We've just updated the extract patient-facing website. That's extractclear.com. I did drop that in the chat for anyone that saw that. So those are just two housekeeping questions that I'm able to help with there. But if you have questions, please continue to reach out, contact your local Strata sales rep, and they can always put you in contact with all the great resources we have to offer, patient practices.
Well, thank you, Dr. Glick. Thank you, Strata. Thank you for all attending on this Monday evening. Like I said, if you have any questions, please, let us know and we'll get you in contact with the correct resource. Thank you.
Thanks again. Thanks, Dr. Glick.
Good night.
Thank you all.